Hello and welcome to Workers' Comp Unwrapped, the podcast that simplifies workers' compensation for physicians. So let's get started. Welcome to Season 3, Episode 25 of Workers' Comp Unwrapped. I'm Anique, your host. Today I'm joined by Angela, who brings 15 years of experience in the workers' compensation industry. We're talking about telehealth in workers' comp, what's working and what's getting denied. So virtual care is, it's absolutely established now. It's not some experimental feature anymore.
Not at all.
But what we're seeing in 2025 is this massive structural tightening. Payment rules, documentation expectations, and especially utilization review scrutiny. It feels like they've all ramped up significantly.
That's the perfect way to phrase it. Payers have finally caught up to the technology. Telehealth isn't a temporary thing anymore. It's a permanent part of care.
And because it's accepted, they're scrutinizing it more.
Exactly. They're able to ask better questions, And when a provider's request for authorization, the RFA, or their clinical notes don't answer those new, tougher questions, well, that's when denials happen. And they happen with a frightening predictability.
Okay, and before we really dive in, just a quick disclaimer for you, the listener. The rules for telehealth in workers' comp can be really different, depending on the state and even the specific payer.
Highly dependent.
So today, we're really focusing on the general patterns, the big trends we're seeing across the industry, to give you a framework for where you might be vulnerable.
And understanding those general patterns is critical. The reasons for denial, they tend to be pretty consistent, even if the specific rules vary a little from place to place.
Okay, let's unpack this big shift. Compared to, say, a few years ago, what is the fundamental paradigm shift here? Has the resistance to telehealth just moved?
It's moved, absolutely. The question has shifted from, is this acceptable, to, is this medically necessary and appropriate for this specific patient at this specific moment?
So it's all about the justification now.
It is. The major change is that telehealth is now treated just like any other standard method of care. But, and this is the key, it comes with these very clear high-stakes compliance guardrails.
I think we all remember the early pandemic era. It was all about access. If you could see the patient virtually, it was basically allowed.
Exactly. The mindset back then was allow first, review later. We just needed to make sure patients were being seen.
Right.
The 2025 mindset is mature. It's allow only when it clearly meets medical necessity and the standard of care. The burden is now completely on the provider to prove why virtual care is the right way to deliver care.
So telehealth didn't go away, it just grew up. And that means a much higher standard for the treating physician than ever before.
Absolutely. And that higher standard demands detail, specifically in the treatment notes and most critically in the RFAs.
Yeah.
If the documentation looks generic or, if it looked like it was just copied from an in-person template, that's going to trigger a UR flag immediately.
Okay, let's start with the good news then.
Right.
Where are we seeing smooth sailing? Where can providers feel pretty confident that a virtual request is going to get approved?
Behavioral and mental health services, that's still the smoothest area by far. Think ongoing cognitive behavioral therapy, psychiatric follow-ups, or PTSD treatment that's related to the injury.
And why is that category so consistently successful?
Well, because the core of the treatment, the diagnosis, the assessment, it's all verbal and psychological. It doesn't really require physical touch or any kind of specialized equipment.
Makes sense.
But even that smooth sailing is conditional. The documentation has to explicitly connect the symptoms, say anxiety or sleeplessness, to a measurable functional work impact.
Right. That's always the linchpin in workers' comp. You have to connect the complaint to the claim.
Precisely. And beyond that functional tie-in, approval really needs four things: clear medical necessity, documented treatment goals, demonstrated progress over time, and of course that clear link back to the industrial injury. If you have that structure, mental health, telehealth usually gets approved.
And what about for physical injuries? Are there any routine visits that are, translating well virtually?
Yes, generally. Follow-up visits where you're just reviewing imaging or lab results and no hands-on exam is needed, those tend to go through without a problem. Medication management check-ins are also good candidates as long as the injury is stable. And we also see a lot of success with things like care coordination or work status discussions. The key is specificity. The reason for the visit has to be really clear and achievable over video.
All right, now for the part where providers are pulling their hair out. Where are those utilization review triggers just hair trigger sensitive? What's facing the tightest scrutiny in 2025?
We are seeing immediate pushback in, I'd say, three main areas. First, initial evaluations performed virtually.
The very first visit.
A very first visit. Unless there's a really exceptional reason, payers want to know why the foundational assessment of the case wasn't done in person.
And is that pushback purely clinical?
It's about clinical validity. If the injury involves, say, the musculoskeletal system, the initial EVAL requires key physical exam components: palpation, precise range of motion tests, strength testing. You just can't do those reliably over video.
So if the CPT code implies a comprehensive physical exam,
And the note shows you couldn't actually perform those key tests, that's a guaranteed denial.
that seems logical, but I can almost hear providers pushing back. What about a worker in a rural area who has to lose a full day of pay and travel for hours? Isn't that a bigger barrier to care?
That's a fantastic point, and it leads directly to the third denial trigger. The provider has to make that exact argument in the RFA. If the request doesn't explicitly justify why telehealth is the right choice for that specific visit, the payer just assumes it's not.
So it's not the modality itself that's being denied.
No, it's the absence of the why. The RFA might do a great job justifying the need for, say, physical therapy, but completely fail to justify why the initial consult should be virtual. The payers need to see that you've thought it through. You need to explain why telehealth meets the standard of care despite any limitations, maybe due to distance or mobility issues or even scheduling conflicts. If that story is missing, the denial is probably coming.
Okay, let's zoom in right there on the RFA failures. We know generic templates are a problem, but what specific language or information is missing that just derails an otherwise good request?
So many providers are still using, templates that were designed for paper charts or generic EHR templates that just default to an in-person setting. They're missing the specific data points that a UR reviewer is trained to look for now.
Can you give us an example? What's a critical piece that's often missing?
Acknowledgement of limitations. A really strong RFA for a telehealth visit should actually say something like, patient's knee assessment was limited to visual inspection and their own reporting. A full physical exam for palpation will be done at the next in-person visit.
So by admitting the limitation, you're actually strengthening the request.
You are. It shows the reviewer that you're thinking critically about the modality, not just defaulting to it because it's convenient. You need three things in that RFA: the justification for why telehealth, the acknowledgement of any limitations, and confirmation that it still meets the overall treatment goals.
What about the simple administrative stuff, like patient consent? I imagine that gets missed.
It's a huge yet simple compliance failure. It's a best practice, especially if the visit is audio only, that the documentation must explicitly state the patient gave consent. If that little detail is missing, it can cause a denial later on.
Okay, which brings us to the final and maybe most frustrating hurdle: post-service denials. The RFA was approved, the service was rendered, but the payment still gets denied. That just screams billing problem.
It almost always is. It's that gap between the clinical approval and the revenue cycle execution. And the biggest culprit right now is place of service codes and modifiers.
Let's get specific. What are the common POS code errors?
The main tension is between POS code 02 and POS code 10. POS 02 was the original code, but some payers have now moved to POS 10, which is specifically for telehealth provided in the patient's home.
And if you use the wrong one?
The system just rejects the claim automatically, even if the RFA for the actual service was pre-approved.
Wait, really? The RFA can approve the medical procedure, but the wrong 2-digit POS code can torpedo the entire payment.
That is the brutal reality of workers' comp billing. And then you have modifiers. For a standard audio-video telehealth visit, you have to add the right modifier, usually modifier 95, if that's missing, or the note says telehealth, but the claim is coded like an in-person visit.
The inconsistency flags it for denial.
Exactly. And don't even get me started on time-based codes. They are under extreme scrutiny. The provider has to document the actual start time and end time in the note. If you bill a 45-minute code, but the note only supports 20 minutes of actual engagement, they will deny it or downcode it. Everything has to align perfectly.
This is incredibly practical. We've covered the what and why of these denials. So let's finish with an action plan. What are 3 immediate practical steps a provider could take today to improve their telehealth success rate?
3 immediate actions. Number 1, you have to separate your telehealth documentation from your standard in-person templates. They need different fields for consent, for acknowledging limitations, and for justifying the modality. Stop using forms designed for 2019.
Dedicated virtual forms.
Yeah.
Got it. What's number 2?
Targeted training for the staff who handle RFAs. They need to be trained specifically on how to write the narrative for virtual care. They have to know how to articulate that crucial why telehealth is appropriate for this patient right now.
And the third most critical step for fixing these systemic issues.
You need a process to regularly review your telehealth denial patterns. If you get 5 denials in 2 weeks for the same missing modifier, that's not bad luck, that's a workflow problem.
So you're fixing the machine, not just the one broken part.
That's the definition of an efficient revenue cycle. If a denial is predictable, it's preventable.
So the core takeaway here seems to be that telehealth in workers' comp is effective, is necessary, but it is absolutely no longer forgiving.
That sums it up perfectly. Virtual care is a fantastic tool, but it's not a shortcut. It has to meet all the standards for clinical justification, documentation, and billing every single time. The days of relaxed oversight are long gone.
This has been an incredibly valuable deep dive. Thank you for providing the kind of specific technical clarity that providers really need to navigate these tightened 2025 rules.
Of course, it's always a pleasure to help clarify these complex systems.
And to our listeners, if telehealth is part of your strategy, now is the time to audit those RFAs, tighten up your documentation, and make sure your billing codes are perfectly aligned. Because in workers' comp, specific knowledge is payment. Thanks for listening to Workers' Comp Unwrapped. If you found value in today's episode, subscribe and share with fellow doctors. Stay informed and keep making a difference in your patient's care.